Yeah, thank you very much for being here. It's an honor for us as the Brazilian Society of Intervention to have you in this webinar. I know that for us it's an honor, and all this you know, but just to reinforce that this webinar we created to, one idea is to education, but also to support fragile communities that in this COVID times are with food insecurity. So thank you very much. I think your presence here collaborates a lot. We did with the money here, we did an action in Salvador, Bahia, in a very poor community. And the next action of our society will be in an Indian community in the Amazon. So thank you very much, Dr.
Wonderful, wonderful. So do you want me to start now?
Yep, please.
Okay, all right. Okay, so I will talk then about the this talk here. I gave not long ago, but I think it gives. Can you hear me? Hello?
Perfect. It's
Can you hear
perfect.
me? Yeah. Can you hear me?
Yeah.
Yes.
Very, very good. Sounds excellent.
Can you see the talk? Not yet?
Not yet.
No.
Okay, coming. Can you see it?
Not yet. It's like dark. Oh, there you go. Yeah.
Perfect. Perfect. Okay, so I want to go over. So can you hear me and can you see me and can you see the screen? Perfect. So I'm moving here with this. Basically, yeah, basically we have, you know, unfortunately we can't live without technology, and we have more and more technology here in interventional radiology in the operating room, and we have the mutations that are important also for predicting the prognosis, and we have to combine both here. And what I want to talk is be very specific here with the different types of presentation for colorectal liver metastasis. You have the small metastasis, you have the bilateral metastasis, you have some that are synchronous with liver and lung, and then we have the multiple mutation and the biology, and you have to take into account all of them when you operate. So we do more and more parenchymal sparing surgery, and we have improved survival when we don't do big resections. So this study was done on tumors single 3 centimeter or less, and we compared where, in these patients, the patients who had the right hepatectomy to those who had sparing a portion of the right lobe, and we found that they had better survival if you were trying to preserve the right lobe. So we tend more and more to resect portions of the liver, and what I'm going to present is very relevant to this parenchymal sparing approach. So these patients presented, they survived also better when they were re-resected. So this is an example of extreme parenchymal sparing, but very important. You see this small metastasis here, and we mark the metastasis before the surgery, and we target them and we find them, and it's easier We don't search for metastasis. We don't do blind resection. And we give chemotherapy in more than 90% of the patient before surgery. We feel it's good. It's good. You can schedule the surgery. We give like 4 cycles of chemotherapy. Sometimes we give no chemotherapy afterwards, but we give it before 4 cycles. It's very simple. And since we encounter small metastasis, we like to localize them. So with the fiduciary, it's very easy, very good. And we do that for small ones at risk of disappearing. Not all of them. You know, if you were to do a right lobe of this patient and there are like 4 or 5 small metastases, you wouldn't mark them, but here we mark them. And if they are deep, we mark them. So that's an example also of marking here in the paracaval caudate lobe, very, very deep in a 35-year-old male. We didn't want to ablate there. And you know, this area may be dangerous when you ablate because it may be close to the bile duct. It's the back of the paracaval caudate. So you may not want to ablate there either. And it's deep and it's right on the cava here. You see the cava, it's right there. It's right on the cava. So we marked here and it was a re-resection and we placed the fiduciary and we resected. You see, you can turn the liver upside down and we were just, we dug a hole there and we had a good margin and good resection. So you need to optimize the, also the treatment of these small metastases is ablate them correctly when you decide to ablate, obviously. And this is from the Memorial Sloan Kettering, and they looked at the margin of ablation, and they found the best prognosis in those patients who had a margin of ablation of greater than 10 millimeters. So it was using 3-dimensional monitoring of ablation and CT. So our recommendation is if you plan to ablate, just do it in interventional radiology and not in surgery. If you do it in surgery, invariably you will be not ablating enough or ablating too much. You really want a precise ablation. Like you do precise resection, do precise ablation. And this is a software that Bruno has developed here. Now we are testing and which will help us really devise, you know, this patient needs 5 millimeter, this patient needs 10 millimeter and all around and in 3 dimension. And this is important in the era of RAS mutation because you see this this here graph showing that even in small metastasis, if you are RAS mutant, you have a very high risk of local recurrence compared to RAS wild type. So it's important also to know the RAS status, and you obtain it. I think in your country you use cetuximab, so you have the RAS status. So it's important to know it. But even for small metastasis, and you look here, also the small metastasis here, less than 2 centimeters, you see very early recurrence, even in small one, progression. In blue, you have the RAS mutant, and in red, you have the RAS wild type, and the RAS wild type tend to recur late and tend to recur if they are bigger than 2 centimeters. So watch your ablation margin if you can. So that's our recommendation. For resection, it's more controversial right now, the margin of resection. But I think for ablation, this was confirmed also by a multi-center study from Italy and Memorial Sloan and MD Anderson. Sorry, Bruno, not Memorial. Post-resection, completion ablation, when you are unable to identify tumor intra-op, there's central lesion requiring extensive functional resection and an incidental lesion precluding safe resection. Sometimes you find an incidental lesion and you can't resect it. You can't, so it's too much. So don't do too much. Sequence the procedures, plan the procedures with the interventional radiologist. This is an example here. This is a resection extended left. You see that we are just in the middle of a surgery. We did an extended left here, resected this. We resected this, but we couldn't find this lesion. And we knew it was there from before the surgery. We knew it was there, but we couldn't see it with ultrasound. So it's visualized by CT pre-op, and we go post-op after the surgery. We're not worried about it. After the surgery, we ablate the lesion. So it's a new concept, you know, it's planned R2 resection. It's a concept. So we don't necessarily say we need to resect everything, you need to clear everything. You can have a final touch by a skilled radiologist in the radiology suite, 4 weeks, 6 weeks after the surgery, and outpatient procedures, patients do well. This is what we found here when we compared. I have to say now the p-value here is significant for this local recurrence. We have a p-value of 0.03 in fact, and it's published in fact. It's in press in a European Journal of Surgical Oncology. So if you do intra-op ablation, you have a higher chance of recurrence compared to completion ablation. So you should do completion ablation. Bilobar mets, that's another topic. Bilobar mets are often treated with 2-stage hepatectomy, first stage, second stage. First stage minor resection. You don't do much. You resect small metastasis, and then the patient gets a PV. That's a traditional approach. Then you do the major hepatectomy. 2-stage hepatectomy at MD Anderson. We, in fact, have a high rate of completion. Dropout was 18%, 20 of 109 patients. And the reason for the dropout, patients who don't get the second stage, is a lot of reasons: progression, insufficient regeneration, medical comorbidity. 80 patients underwent PV. The future liver remnant was very small, 18.5%, and on average it increased to 30%. And we now do the first stage and the portal vein embolization in a hybrid room at MD Anderson. The hybrid room has several components here: robotic C-arm, a multi-slice CT on rail, a fluoroscopic table, and we can do 3 encounters in one, because the patient comes and is put asleep. We do the first stage resection. We close the patient. Immediately after that, we do the portal vein embolization. And we use the same technique we would use normally, percutaneous portal vein embolization with or without segment 4. And then we do a CT, and that's the baseline CT post first stage resection. So this is what we get here. We get an accelerated 2-stage, because we don't have to wait for the portal vein embolization after the first stage hepatectomy. And this is us here with our first case, in fact. 2 resections, but in segment 4, we resected 3 metastases, which we had localized with fiduciaries. And in fact, I saw the patient, that was yesterday. I saw her on video conference yesterday, and she's still alive 2.5 years after surgery, has no recurrence. We did the second stage, obviously, after that, but she had very good response to chemotherapy. And this is the post-op CT, so that the second part of the procedure, in fact, if you will, it's very convenient for the patient. They come to the hospital once and it's all done. So that's our first 11 cases, total operating room time. So it's you know, 4.5 hours, major complications 0, and length of stay 3 days. Now, synchronous lung metastasis, I think it's an important topic for us. Lung metastases do not contraindicate liver resection. And we use the transdiaphragmatic approach. We use also interventional radiology in some of these patients who get ablation. But when we can, we do transdiaphragmatic resection, and it's perfect for lower lobe, for peripheral lesion. When they are too small, we don't do it. And when it's deep and big, we don't do it. So not wedgeable, too small. But we do, after the liver resection, a small incision. And I'll see if I can show you. That's our thoracic surgeon. Wow, it works. Making the incision, a radial incision in the diaphragm. He has big hands, but he can feel those metastases very, very well. He has big hands, but you see the stapling and it's out. It's adding about 20 minutes to the procedure. We put the chest tube and you got the closure here with a running suture, and that's it. The chest tube is removed the following day. So that's very, very practical for us. So you can feel more lesion. You have the palpation, you know, the lungs are deflated. There's an endotracheal tube, bilateral endotracheal tube. So we deflate the right lung or the left lung. We've done both sides in same patients, right and left. Sometimes you feel more like nodules, and we resect them if we can. And we have found out that, you know, sometimes it's positive, sometimes it's negative, and there are a lot of granulomas and nodules in the lung, but it's a useful procedure. And here you see that we now, with simultaneous resection, we have done more major liver resection. We used to do, when we did major liver resection, we used to stage. We said we do a major liver resection, we'll do a thoracotomy later in 2 months or 3 months. Now we do that here with 41% were major liver resection. So we're not worried about bile leaks. We do bile leak tests. We can minimize bile leaks with a precise surgical technique. So we're not worried that bile is going to go in the chest. Now, another example here is a large resection here in a patient who had unresectable lung metastasis. That's the other end of the spectrum, patients with unresectable lung metastasis, but they have liver metastases that are resectable. We tend to resect these patients. And we found that the survival of these patients is intermediate. In the blue line here, the survival is intermediate compared to patients who have liver and lung. These patients have an intermediate survival. There are subsets of these patients, and the ones that benefit the most are the ones with RAS wild type. Now I'm going to talk about multiple mutation. You need to know about RAS, but you need to know about other mutation. This patient recurred very quickly after a liver resection, a big resection, extended left with partial right, and there was recurrence there in the liver, there was recurrence in the lung. And I said to myself, you know, it's not only RAS, there was something. So we have the 50 gene somatic mutation panel here, and we can see the mutation. And I realized that a lot of patients had TP53 mutation. And TP53, if you look at it, it's very common in colorectal liver mets, more common than RAS. And in fact, if you look at cancer, the lifetime risk of cancer appears to be higher in bigger organisms, and it's higher in humans and in dogs. And in fact, the taller you are, there's even a study looking at your height, at the height of an individual in population, and the taller you are, like Bruno, you are higher risk of cancer. Bruno is high risk. And if you have the Li-Fraumeni syndrome, you have a very, very high risk because of TP53. And what was recently discovered 4 or 5 years ago is that you have these big organisms there. They are huge, but their risk of cancer is very, very low. So they have multiple copies of normal TP53. They have like 40 allele, 20 times 2. And that's you see, that's 2018. It's a very recent discovery. And that puzzled a lot of people because they are exposed to the sun and everything. So they live a long time. So this TP53 is acting with RAS. And if you have double mutation, RAS TP53, the survival is worse here. So you have to look at co-mutations, and I think it's going to come more and more. And I'm sure we're going to look at ablation and double mutations soon, right, Bruno? You're working on that, I'm sure. And other things we could look at with this 50 gene panel, but we understand more and more. But it's useful if you have to decide, am I going back to surgery in this patient who just is recurring? Am I waiting? Am I sending the patient for ablation? Am I giving chemotherapy? Which kind of ablation? There's also SMAD4 here, and I'm going to stop with that because there are a lot of other mutations. SMAD4 is also associated with worse prognosis, and particularly in association with RAS. So double mutation or triple mutation, you have RAS, TP53, SMAD4, it's worse. And that's an example here of the different survival. In fact, you have only RAS mutation, and 20%, 20 to 30% of patients have RAS only, not TP53. They are the same as RAS wild type. So what we've been talking about for quite a while about RAS, we were talking about probably RAS TP53. So that's the pathway here, like 3 pathways, relevant pathway are presented here: MAP kinase, TP53, and TGF-beta. In fact, there are 5 relevant pathways, but that's going to be for another time. I don't want to take too much time, and maybe we can discuss the approaches. Thank you very much for the invitation.
Thank you, Dr. Vauthey. It's incredible talk. I think as interventional radiologists, we have to understand, or surgeons, we have to understand more the biology, and the choices of therapy must be run by this, not just for the size or the location, but the biology for sure. Thank you very much.
Thank you.
All right, I think now it's my turn.
Bruno.
I will share my screen. Let me see if I can make this. Can you see my screen? Can you see the presentation? Okay, all right. So I'll try to go over these, and apologize, I speak in English. And Dr. Vauthey, I think he's a surgeon, but he could be very much an interventional radiologist, because a lot of what I'm going to present here, he has already presented. And I'll try to make these brief and a little bit more focus on the technical aspects also of the microwave ablation technology. So those are my disclosures. So as Dr. Vauthey mentioned before, the role of interventional radiology, there are two different types of disease when you're talking about colorectal liver metastasis. You have patients with small, limited colorectal liver mets, and they can be treated with ablation. And you have patients with advanced colorectal liver metastasis, where as interventional radiologists, we can apply some other local regional therapies, such as portal vein embolization, Y90, chemoembolization, and fiduciary markers. We're just going to talk about ablation today. And why we're doing ablation on those patients. There is a recently randomized phase 2 trial published in Europe from a European consortium of different countries there, where they perform this very long analysis comparing the use of chemotherapy alone on patients with colorectal unresectable liver metastasis versus chemotherapy plus radiofrequency ablation, not a microwave, because this is a relatively old study, and they didn't have this technology at the time. And they show that on the 10-year follow-up period, there was a survival benefit when you combine ablation with radiofrequency ablation to chemotherapy compared to chemotherapy on those patients with colorectal liver metastasis. There is a nice commentary about this paper from Dr. Chan and Dr. Vauthey also, which is interesting to get the idea. This paper, it's a paper that in about 50% of the patients, there was a combination between ablation and resection. So it's not only a ablation paper, it's a surgical paper in the vast sense. Also, the vast majority of the patients who had ablation, they had intra-op ablation. They did not have percutaneous ablation. So I think this paper also speaks to the how much we combine our therapies and how much surgeons and interventional radiology, they have to walk hand to hand on the management of those patients. Here on MD Anderson in 2012, we acquired our first microwave machine. And since then, based on the positive feedback we had using this machine, we pretty much replaced all the liver ablations we are doing today, over 95% actually, we do with microwave ablation. We don't do with RF. We still use RF in a very few cases if you have a tumor that is very small and close to a critical structure, such as a major bile duct or the gallbladder. And the reason for that is I'm going to explain a little bit later, but microwave ablation is such a powerful ablation modality that it tends to create an ablation cavity that is not so predictable, and you don't want to cause any damage when you do that. And we have faced some issues with health insurance, and so sometimes the health insurance denies the use of microwave, and we ended up using RFA, but most of the times, over 95% of the times, microwave is our ablation modality to go. This is a paper that Dr. Vauthey already alluded to, and this is just to show that over 70% of the patients who have colorectal liver metastasis and they go to resection, they ended up having a recurrence down the road. Therefore, we need to keep from the very first time when we see those patients on the clinic, we need to keep in mind that they probably will recur, and we need to provide a local regional therapy that will be effective in taking care of the tumor that they have, but also that will provide us the ability to rescue those patients at the time of recurrence. And I think on that context, a liver ablation has a nice, interesting role. So microwave ablation, in terms of physical properties of this technology, it works as an antenna. It's not a simple probe. So it generates a microwave, a wave, and this antenna generates heat from the tip and goes all the way to the back. So the greatest advantage of microwave compared to radiofrequency ablation from the physical standpoint is you don't rely on tissue impedance to create the ablation cavity. On RF, you rely on tissue impedance to disseminate the heat and the destruction. On microwave is a little bit different. And because of that, you ended up having larger ablation volumes when you use microwave. You also reach higher temperatures. And there are some in vitro studies showing that when you achieve this higher temperature faster, you ended up promoting less pro-oncogenic effects associated with the ablation. And because on the transition, the ablation transition zone, you could potentially create some pro-oncogenic inflammatory process there. And with microwave, you reduce that. And because it's an antenna, it doesn't provide a perfect round sphere. There is always a little bit of tail when you use microwave ablation, and that causes, by consequence, some unnecessary tissue loss. You end up ablating things that are not necessarily need to be completely ablated on that area because you're not incorporating tumor. So the ablation volume when you use microwave ablation is essentially dictated by two main variables. The first one would be the time and the power. There is a third variable that as we use this technology more and more, we see that the dielectric properties of the tissue, they also affect how the ablation will go. Like for instance, patients who receive oxaliplatin, which is a backbone of chemotherapy for colorectal cancer, those patients, sometimes they develop a sinusoidal obstruction on their liver, and the liver becomes quite congested. And when that happens, you ended up having larger ablation zones. On the other hand, patients who receive irinotecan, they might also develop steatohepatitis, and the steatohepatitis, it tends to make the ablation cavity a little bit smaller. So you need to take in consideration those variables on a patient level when you apply any ablation modality, actually. So this is one of the very first patients we did an ablation several years ago. He had a right hepatectomy and recurred with a lesion, solitary lesion, segment 4, and we performed this massive hydrodissection to move the colon away because we know that we're going to create a large ablation margins, and we use 2 antennas. This is the lesion here, the tumor on the ultrasound, very close to the colon, as you can see here. So we also performed some hydrodissection, as you can see there, and we ended up with a nice ablation. This is only 6 minutes of ablation. You ended up with a 5.3 by 4.5 ablation cavity. The size of ablation, it's quite critical, but as Dr. Vauthey mentioned already, it's not only a matter of size. You need to make that size, the ablation cavity, be very well positioned in relationship to the tumor, because you need to provide sufficient ablation margins. And we know now that ideally you should always aim to get at least 1 centimeter of minimum ablation margins on those patients, especially when they have RAS mutational status, because this is the paper that Nick mentioned before. This is a combination of the MD Anderson data with the Italian data, where we show that when we have RAS wild-type patients here represented in blue, and RAS mutant-type patients here represented in red, when we get more than 1 centimeter ablation margins, and the patient is a wild-type RAS, we are talking about over 90% of local tumor control on 3 years. On the other hand, even if you achieve more than 1 centimeter minimum ablation margins on patients who are mutant type, at 3 years, their local tumor progression is much higher than the wild type. So there is so much you can do with ablation. You need to take in consideration also the tumor biology of those patients. This is about the software that Nick mentioned before. We are being almost obsessed with the minimum ablation margins in a 3-dimensional fashion these days. We need to achieve as much as we can over 1 centimeter margin, especially if the patient is a mutant RAS patient. And this software, it's been quite helpful for us for now. This is another patient where we are prescribing the need of maximum ablation margins in a safe manner. So this patient had a right hepatectomy and recurred with 2 tumors, one segment 2 and another one segment 4A. So this is a segment 2 tumor. And when we have a patient with a small liver remnant, what we're doing now is we put a catheter on the celiac or the common hepatic artery. We do transarterial access and we inject contrast as we ablate those patients. And by doing that, we can see the minimal, the ablation margins as we are delivering the ablation to those patients. So that makes the procedure much safer and much more effective in our opinion. This is the post-ablation. This is with an IV contrast injection. You can see that we got this very large ablation that covered the entire tumor on segment 2, but also on segment 4, as you can see there. And that's the not an issue with microwave, but you need to be very careful because it can create pretty large ablation cavities, and you can end up damaging critical structures that we're not planning to ablate to begin with. So one thing that is quite useful with microwave is it tends to be less affected by what we call heat sink effect. If you have a tumor close to a major vessel, like this patient here who had this tumor adjacent to the right hepatic vein, you tend to get larger ablation cavities when you use microwave ablation in this case. But nevertheless, if you really want to get a larger ablation, so this is a patient with a RAS mutant type, with a tumor sitting right next to the right hepatic vein, you need to do, you got to be a little bit creative. So on this patient, we got a transhepatic access. We put a balloon occlusion catheter on the right hepatic vein, and we place the probe, the microwave antenna, right here, and we inflate the balloon catheter into the right hepatic vein to reduce the chance of heat sink effect, and we deliver the ablation. And this is something that we're seeing a little bit more frequently. I think this is the other side of the coin when you use microwave ablation. It tends to create more clots than radiofrequency ablation. So this patient, at the end of the ablation, he had a little clot here. We have about 5 patients who had clots after microwave ablation adjacent to the right hepatic vein. And most of them is just an incidental finding. They might present with some pulmonary embolism down the road. But what we're doing now is when we ablate a patient with a tumor right next to the major hepatic vein, we put those patients on prophylactic anticoagulation for 15 days. And it seems to be working. We don't have enough patients to say that, but it seems to be an effective therapy. So this is the final result of this patient. We have an over 5 centimeter ablation cavity right next to the hepatic vein. This is a 1-month follow-up. The hepatic veins were open, no clots, no issue whatsoever. One thing that we also investigated together was how patients who had a prior hepatectomy, how do they behave if you offer a liver ablation to those patients? And we saw that compared to patients who never had a hepatic resection before, the patients who have a hepatic resection and they recur after the hepatic resection, and you apply ablation to those patients, you ended up having much better local tumor progression rates. You control the tumor much better with ablation than patients who never had resection before. And the overall survival also was different. So I think this speaks about tumor biology and patient selection to go to hepatic resection for colorectal liver metastases, and that provides a sustained benefit for those patients. So this is a patient population that you really need to be aggressive, because if they made to resection and they present with a new tumor in their liver, if you apply ablation, there is a really nice chance that you're going to be very successful in those patients. So this is a patient just like that. She had a recurrence just adjacent to one of the resections on the right hepatic lobe. She had a very small liver, and we got a catheter, transarterial access, put a catheter on her common hepatic artery. You can see that the blood flow was quite slow on her. She was on bevacizumab before the ablation. And this is how we've been doing those patients with limited liver volume. On the left side, you can see that we did a transhepatic approach. We identified the tumor with transarterial injection. We placed the probe here on the middle screen, and we inject some contrast as we ablate those patients to make sure that we are achieving a decent ablation margins on them without any complications. And this is something that Dr. Vauthey also mentioned, this idea, this concept of post-resection completion ablation. Typically, we apply that for 3 different scenarios. You have a patient that has a tumor on a given location on the liver, and you resect part of the patient's liver, but there is one tumor that you cannot identify for any given reason. Maybe the liver parenchyma is too heterogeneous, or there is a difficult access to perform intraoperative ultrasound, or if you have a central lesion that that is going to require very extensive liver resection, and that's going to reduce the amount of functional liver post-operatively, so you don't want to do this resection. Or if you have patients where you found this incidental lesion during the intraoperative ultrasound, and that would change the treatment, the surgical treatment plan for those patients. So what we do is we perform the right, like on this case here, we did the PVE, a right hepatectomy was performed, and then this patient had a small liver met right here on the segment 4, and that would require extensive resection. So instead of doing this extensive resection, we brought the patient a couple weeks after the surgical resection. We did the percutaneous ablation, and we took care of the tumor. And this is the most recent data. This is hot off press, has been published I think 2 days ago on the European Journal of Surgical Oncology. We show that when we use percutaneous ablation under CT guidance, our ability to control the tumor is significantly better than doing intraoperative ultrasound-guided ablation. So that's the rationale why we are going to close those patients, bring the patient later, and do another general anesthesia procedure and do these procedures and those ablations under CT percutaneous guidance, because we achieve better local tumor control when we do that. And also, which is equally important, is when we do the completion ablation pathway, resection, close the patient, bring the patient later for ablation, those patients, they have significantly lower complication rates than when we combine intraoperative ablation and resection in the same setting. This is probably because we are generating more metabolic response, more trauma to the patient when we do intraoperative ablation. So it's a twofold gain, one in oncological outcomes in terms of controlling the tumor, but also in reducing the chance of having a complication associated with ablation. So conclusions, microwave ablation for colorectal liver mets has been the standard of care ablation therapy at MD Anderson since 2012. The positive aspect of this technology, it creates larger ablation zones, and we need that based on the literature. We know that it's absolutely critical to get decent minimum ablation margins. The problem with microwave ablation is you ended up having a less predictable ablation zone, so you need to be careful. You need to get CT with IV contrast once you finish the first round of ablation to make sure that you don't over-ablate those patients or under-ablate them. And for colorectal liver mets in general, ablation is an effective local therapy combined with surgery or used in isolation selected patients. I think it has a critical role for salvage at the time of recurrence of patients who were submitted to resection first. And we use ablation in a less restrictive use than surgery. But this less restrictive use, I think this is the most important message of my lecture, is you should still take in consideration patient's context. You need to take in consideration tumor biology, how aggressive the disease that patient has, because you using indiscriminate way ablation just for using that, we're not going to provide any benefit for those patients. So you need to be very critical about patient selection, how to use that in the best interest of them. And that's it. I'll finish with a picture from PRVG in Bahia. This is just like to say thank you to Marcos and Sobrice for the nice action. You guys did that a couple weeks ago. I think it's really nice to have a society as our society acting for the good of our population. So thanks so much for the action and for the invitation.
Thank you, Bruno. It's very interesting, the data that you get. I think we already have discussed this before, but this impression, it's nice to now you have the data, because from my impression is that intraoperative ablation is much more tough than to do that percutaneous. And I think we get much more precisely when you do that percutaneous with image guidance and post-image control that we don't have in intraoperative. And it's really nice to see that. One question that I have to you in terms of microwave, how do you care about thrombosis? If you are near to a large vessel with the needle, in RF you don't really care. You have the heat sink effect. In microwave, you don't stay very close to a vessel, or it's not an issue for you?
Yeah, I think with microwave, I tend to care more about thrombosis of a major vessel. Specifically talking about portal vein and the hepatic vein, right? The hepatic vein, my concern with thrombosis is the theoretical chance of creating a massive pulmonary embolism episode on those patients. We never had one patient who had a massive one, but theoretically it's possible. So that's why we put those patients on anticoagulation. We give Xarelto, 2.5 milligrams twice a day for 15 days. And for pleural vein, I think for pleural vein, we tend to be less restrictive about the thrombosis. The exception I would make is if the patient has a limited liver remnant. Patient had resection, has a very small liver, they really need that segment, so we cannot infarct that segment. So we try to be, it's a balance, right? We have to see what are the surgical options. If surgery would provide a better resection, cleaner resection, leaving more functional liver remnants. But in general, we try to be careful, more careful with microwave ablation than RF.
Thank you. Paulo, do you have any question?
Yeah. First of all, I would like to thank the invitation from Sobrice and my friend, Professor Marcos Menezes, for his excellent webinar and for the humanitarian proposal of these webinars. This is really fantastic. And it's a pleasure to be here with two good friends, Professor Odísio and Professor Vauthey. And I have a couple of questions to both of you. Starting with Professor Vauthey, have you ever experienced cooling the bile duct by inserting a tube at the cystic duct to make an intraoperative ablation near a bile duct?
So I have, asked, in fact, my interventional radiology colleagues to do that. We've done, I think, twice. I don't think Bruno has done it, but I've done it twice, rarely. This requires a placement of a percutaneous transhepatic catheter for cooling. But yes, so we've done it twice. So it's doable, but I can't give you, an experience with two cases. But I thought it was necessary to ablate, was necessary to protect the duct.
One more question. If you have a patient with a single 2 centimeters or 2.5 centimeters nodule just in the middle of the right lobe, single nodule, what would you do nowadays, resection or ablation?
I think that's a tough question. I wouldn't do a right lobe. That's the number one. I think it's a mistake. But again, it depends on the location. You give me a general question here. The right lobe is in the middle. Where's the middle? What's the middle? If it's near the bile duct, between anterior and posterior sector ducts, on the right side, I wouldn't ablate. I would, because it's dangerous. You're gonna have a big biloma there. I mean, if it's the more centrally located it is, the higher the risk of injury to the bile duct. And if it's a small one can be a dangerous one. So a small one is not a small problem because it's small. And, a small problem, just we're gonna microwave. No, the answer is not to microwave based on size, but you have to study the location and then determine. So there are cases where I would resect. If it's a 2 centimeter, I would first give the chemotherapy. If it's 2.5, 2, I would give chemotherapies. Less than 2, I would put a fiduciary. And then if it's still single and it's in favorable location for microwave ablation, I would microwave ablate, sure.
Thank you. Bruno, I have 2 questions. First of all, what are the rules? Up to 5 nodules, up to 3 centimeters?
Yeah. Yeah, we typically don't ablate patients who have more than 5 tumors, measuring more than 2 to 3 centimeters. If you have a patient with 5 tumors, and those tumors are 2.5, 3 centimeters, 2.8 centimeters, I'll probably not ablate in that patient. I would try resection. If you have, it's not only a matter of the size, but also the distribution. You need to, the lesions, they need to be in a distribution that you can perform the ablation, achieve the maximal ablation margin in a safety manner. Yeah, so typically up to 5 lesions, up to 3 centimeters.
Last question. Do you have any experience with contrast ultrasound to evaluate the ablation fight?
I have very limited experience because the contrast ultrasound was just recently approved by FDA. But when we compare with CT, I think it's much harder to create a three-dimensional picture on your mind of where the tumor was and where is the ablation margin. And the reason I say that is we did this with the software that we are developing right now. The gold standard before that is you get a CT scan and you, using a ruler, you mark where the tumor was and where the ablation cavity is now, and then you try to get the minimum ablation margins. And we thought that we were doing great by doing that. But when we applied the software, we saw that in a very large number of patients, the minimum ablation margin was much, much shorter than we anticipated based on this ruler measuring. And we did a sub-analysis of 30 patients, and some of those patients, they have recurrence. And in 80% of those patients, the software showed that what we call recurrence was actually an unablated tumor. We ablated the tumor and we left some tumor behind and the tumor just grew. It was residual disease. So I think the CT or any cross-sectional method that you can really reconstruct in a three-dimensional fashion in an accurate way is the way to perform ablation on those patients.
Bruno and Dr. Vauthey, one question of our chat is, when you have a patient with mutated KRAS, that change your way to operate it? You do more larger resection or larger ablation? You change your planning, or it doesn't change?
Bruno will answer for the ablation, but I mentioned that, we would recommend that, but you can be more specific, Bruno. Regarding the resection, I don't think the data is quite there yet. We showed higher rate of positive margin, a narrower margin in patients with RAS mutation, but to be really fair, you will have, and to show that KRAS mutant needs more margin, you have to look at recurrence rate, local recurrence rate, and very, very few paper, and in fact, there's no paper looking at local recurrence rate. There may be, well, there's a paper from China, but I think this needs to be verified. So for resection right now, we do an ultrasound, we aim at a negative margin. We do an ultrasound, we aim at 10, but we end up typically with 5-6 millimeter margin, and we don't decide differently between RAS mutant and RAS wild type. Bruno, you want to comment on ablation?
Yeah, on ablation, we always try to go for at least 1 centimeter ablation margin in all planes. Sometimes you cannot do that, and then it becomes sort of like a compassionate use. It's better to do an ablation with 5 millimeter margins and not offer ablation. So it's not like if you cannot get 1 centimeter margin, we are not going to offer ablation for a mutant RAS patient. We're still going to do it, but we are going to do that and talk to the patient in the clinic, understanding that the success rate is not going to be so high. And I don't know, we'll play a little bit of the devil's advocate here, favoring surgery, but the fact that they haven't shown that RAS mutation, it's not associated with a higher recurrence rate on surgery, probably relates to the fact that they achieve better resection margins than we achieve ablation margins. So I think their threshold presently is better than ablation. That's why I'm pushing so much for using CT and having software guidance so we can provide such a effective therapy as surgery for those patients.
Bruno, at the same subject, have you studied other biological bad prognosis factors regarding ablation margins, or just RAS?
Not yet, because a RAS mutation, about 30 to 40% of the patients with colorectal liver mets, they have a RAS mutation. The other mutations like BRAF or SMED, they are much less frequent. So I would need to get our data together with Marco's data and the Memorial Sloan Kettering. We have to do like a multi-institutional study to detect a signal there, just because it's infrequent at least on the ablation population we treated here.
Any other question, Paulo? I think we achieve our 1 hour time of a webinar, and give more for the guys in Houston, have to come back to home and this kind of stuff. Paulo, do you have any other question?
I'm happy. It was really a pleasure to be here.
Pleasure to be here. Again, we just say thank you for you, Bruno and Dr. Vauthey, to be part of this meeting. It's a really honor, and I think it was a really good talk. I think microwave it's a little new, and most of interventional radiologists don't have or little or any experience in it. But I really believe that this technology is the way to move in liver. Particularly liver and lung, and particularly in colorectal mets that you need large margins. I already tried to change all my practice to when you do liver mets with a microwave. We have some issues in terms of insurance companies and whatever, but I really think that microwave is the way to move in terms of ablation. And I always we talk with Bruno that the way also for ablation is precision. We need precision. We need to control the same way that the surgeon, when they finish, he has margin or not. We have to do that the same way with imaging. And that is the new phase of therapy, the ablative therapies. We need softwares. We need image control, and we need a powerful device that is microwave to do this better job. Thank you very much for everybody here and for the participants also. Bye.
Thank you for the invitation.
Thank you very much. Thank you for the invitation. Bye. Sorry for being late. Thank you.
Bye.
Thank you. Bye.
Bye.
Bye, Paulo.
Nice to see you.